Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jennifer Swanson. Today's episode features content from an educational program titled Shingles in the COVID-19 Era, Increasing Shingles Vaccine Uptake. During this podcast, Dr. Dalilah Restrepo, an infectious disease specialist from Fountain Valley Hospital in Fountain Valley, California, discusses the interaction between shingles and COVID-19, barriers to shingles vaccination, and strategies to increase vaccine uptake, particularly in the COVID-19 era. For more information on Dr. Restrepo and a link to the full online educational program, including downloadable slides, please visit the show notes for this episode. So let's get started and hear what Dr. Restrepo has to say about increasing shingles vaccine uptake in the COVID-19 era.
Hello, everyone. I'm Dr. Dalilah Restrepo. I'm an infectious disease specialist, and today we're going to take a little deeper dive into the interaction between the COVID-19 pandemic and vaccination against herpes zoster or shingles. We'll also discuss expert guidance on overcoming barriers to routine vaccinations in adults and strategies to increase the vaccine uptake. So we could see the pre-COVID-19 pandemic, there was already an incidence of shingles increasing over time. Retrospective cohort studies of medical records confirm shingle cases increasing in the latter half of the last century, with 58% female and only really 6.6% immunocompromised, which I find interesting because we're always of the knowledge that it was a disease that flared in the immunocompromised. But age and sex-adjusted incidence of shingles showed increase of over fourfold. Between 1945 and 1949, it had 0.76 per 1,000 person years, and by 2000 to 2007, that number was 3.15 per 1,000 person years. And this isn't particular to the US. There are similar increases seen in other studies across the world. And this trend did not change at all despite use of antivirals and use of the varicella vaccine after the mid-90s. But several mathematical models have tried to predict trends over the next 30 years. And in two scenarios, one assumes a linear trend, or a second scenario, which is a more conservative model, using shingles incidence in the last reported year maintained and predicting these changes throughout 2030. And despite the regular scenario one, or the more conservative model, there was either way going to be an increased cases of shingles over the next years until 2030, resulting in $4.7 billion cost to the healthcare system by 2030. So what is this shingles relationship with COVID? As everything now, we're trying to clarify this as data comes in. You have several case reports in the literature observed of varicella zoster virus reactivation during or after or pre-SARS-CoV-2 infection. And this has been reported in wide age ranges, so anywhere from children to elderly, with or without immunocompromise. And this has been also shown that even a mild case of COVID can result in a very severe shingles reactivation. So there is no linear response to mild going with mild reactivation. It could be seen anywhere in the gamut. And also the hypothesized mechanism is unclear, but one of the hypotheses in some of these case reports have been that it's associated with the low lymphocyte count, which we know is a particular finding on COVID infection. However, there's also retrospective analysis of the role that the COVID vaccine has played in zoster reactivation. So retrospective analysis of the BNT162b2 or the Pfizer vaccine safety in Israel reported an increased risk of herpes zoster in vaccinated persons, looking at over 884,000 patients or persons receiving vaccination versus those unvaccinated and without SARS-CoV-2 infection and followed up to 42 days. And their risk ratio was 1.43 with a risk difference of 15.8 additional cases per 100,000 persons of those among those who had been vaccinated. The study did have limitations. It was not a randomized study. We certainly don't know what the persons that reactivated shingles, what their baseline vaccination status was against VZV. So this is another point in support of avoiding delays in shingles vaccination in the COVID-19 era. So how are we doing with immunizations? This is a survey of 34,218 adults in the US assessing rates of immunizations against vaccine-preventable diseases. The results for shingles vaccine of those greater than 60 years of age were well below the Health People 2020 target of 30% and significantly different among some racial and ethnic groups studied. All ethnicities did poorly, although Hispanic and non-Hispanic Blacks did slightly worse. This disparity persisted even after adjusting for several socioeconomic factors, as we can see described here. Racial disparities decreased but persisted even after this adjustment. One of the most important factors associated with increasing vaccinations was having a usual place of medical care, independently associated with most vaccinations. So also the number of your medical visits in the past 12 months was correlated with increased vaccination status. So concluding that those engaged with the health system were more likely to receive health care, which is something obviously we all encounter on a daily basis. So number of physician visits in the past year increased. If the more visits you had in the last year, the more chances that your shingles vaccine would have been offered and received in those over 60 years. The barriers to vaccination will come as no surprise to any of you. Lack of healthcare practitioner and or patient knowledge about the need for vaccines, it obviously played a major role. Both healthy and high-risk adults benefit from vaccination. And unless we are clear on this, obviously it impacts on our recommendations. Medical management of acute and chronic illnesses usually receives priority over prevention services. And we know busy practices equal shorter visit times, and chronic and acute issues always will take precedent in this kind of scenario. The cost and the reimbursement also was a big barrier to vaccination, as was lack of one trusted clinician or the loss of continuity of care, which of course impacts greatly on all our medical interventions. And then on top of that, of course, you add the COVID-19 pandemic. So clearly all the routine healthcare took a seat during 2020. Vaccinations were absolutely no exception. This is a graph showing the decline in shingles vaccination rates among Medicare beneficiaries during the COVID-19 pandemic. And this was an adult weekly shingles vaccination rate among all Medicare recipients aged over 65. And we start to see 2019 were higher on the list. And then the weeks starting to date of 2020, you see a lower orange bar all throughout. And although it is picking up somewhat after the surges and the lockdowns, recombinant zoster vaccination rates among older adults receiving Medicare are not bouncing back all the way to the pre-pandemic rates. And this is something that we all saw in practice, right? In our quest to really keep infection prevention practices and keep patients out of exposures and exposed areas and minimize exposure to ourselves, we tried to rely on remote and telemedicine and things like of this nature. And of course, I would be the first one to tell you that I told many of my patients, we will deal with the vaccinations or so-and-so next year, or this was all part of our approach in 2020, given what we were going through. But it is important, and I think it is time now to start talking about reinstating these very important routine health interventions. And this is not only seen in shingles, but obviously we have all seen reports of even childhood vaccinations have fallen during COVID and how important this is to now pick up again. So this is a good review of the recommendations on dosing schedules and delays, because again, if we've had this kind of year hiatus, what do we do now with someone that started a vaccination scheme prior to the pandemic, and now we want to pick up where we left off? So shingles vaccination is an essential preventive care service for older adults that should not be delayed or discontinued because of COVID, unless, of course, the person is infected, and then there are infection control practices to be considered. The recommended dosing schedule is 2 doses administered within 2 to 6 months for immunocompetent adults. But if over 6 months have passed since your first dose due to the lockdowns or other reasons, the second dose can be administered as soon as possible. And there is no need to restart the 2-dose series. And I think this is very reassuring for those of us trying to pick up where we left pre-pandemic. So this is adult vaccination standards of care. And again, it's important to have our standards of care for healthcare professionals that are carrying about the vaccination protocols in our office. So ensuring professional competencies in immunizations, and if necessary, refer to a provider who can immunize and who is familiar with immunizations. Assessing immunization status in every patient care and counseling encounter is very important. Strongly recommending the needed vaccinations, as we see, has a very big impact on patients' decisions to go forward with vaccination. Educating patients on the vaccine recommendations and ensuring that the receipt of that vaccine is documented in the health record or an immunization registry. And also communication with the healthcare provider or the primary care physician of the patient is important. So implementing systems in your practice to incorporate vaccine assessment into routine clinical care, we know had an impact. We all need to be a bit more automated sometimes when we're trying to get through a different long lists of tasks during a short visit. So these are strategies to help with that. Now, on standards of care for immunizing providers, one could argue there is a lot to learn about vaccinations. It is not often very simple if you don't do it all the time. But keeping up to date with knowledge of ACIP vaccine recommendations, including contraindications, adverse events, and who and how to report adverse events. And which vaccines can be administered concomitantly to reduce delays is also very important. Keeping up to date on administration techniques and especially storage and handling guidelines, keeping cold chains and the sort, and having up to date and culturally competent materials on hand is important for patient counseling on risks and benefits. Assessing immunization status in every patient care and counseling encounter, strongly recommended needed vaccines, and if possible, keeping the vaccines in stock can be a way to speed up the process. Also having written assessment protocols in place or even an automated pop-up in your EMR can also be a nice, easier reminder. And ensuring that the receipt of the vaccination is documented properly, either giving a record to the patient. Some patients do keep their own vaccination cards, which is really great, or just communicating sometimes with the primary care provider. It could be nice to have a handout and that you can fax over or send to the primary care provider so they know what vaccines you have given to their patients as well. And of all of these, probably the strongest strategy to improve vaccination rates is, believe it or not, that a provider recommended that you receive a vaccine. It is, I think we don't emphasize this enough, but really when patients hear that we recommend that they receive a vaccine, it really does plant the seed and lay the groundwork for them to start considering this. So this can be, again, patient and provider kind of recall or reminder systems, or EMR and IT help with pop-ups can help, or standing orders and protocols in your office. And certainly electronic health record systems with incentives have shown improvement in uptake. Reducing the patient out-of-pocket costs. I know for one, at least in my experience, sometimes I have a very willing patient, I'll have a willing staff, but if the patient's out-of-pocket cost is something they can't afford, then the whole intervention is lost. And I've had to send many patients to get vaccinated in actually the pharmacies, because sometimes it gets reimbursed there, but not in my office. So having that discussion is important. Worksite interventions offering on-site vaccinations can be helpful for those patients that want to just get it all done. And pairing healthcare system-based interventions with culturally competent and community-based interventions is important as well. I, for one, have my handouts printed, and sometimes they're laminated and they can look at them while I prepare the vaccine and such. And it helps to talk about questions and answers that may arise. And certainly if you have it in different languages, it's very helpful. So these are some important resources for healthcare professionals and patients. And these shingles resources can be found at the CDC website. I find them very useful because they also come in different languages. And I like to, again, I have them printed and ready to go in the office, because last thing you want is some paper jam or something in the office when you're trying to have a discussion with a patient over vaccines. So the take-home points are vaccination rates prior to the pandemic were already low. The COVID-19 pandemic has only decreased overall vaccination rates, and we all have experienced this. COVID-19 has only made our already difficult job way more difficult, right? Racial disparities in vaccination rates for shingles, as with every other vaccine, persist even after adjustment for socio-demographic factors. It is important to keep prevention in mind at all times, and vaccination is definitely one of those interventions that, if it exists against a vaccine preventable illness, this is we should really invest in trying to get this point across. The CDC recommends maintaining routine vaccination schedules during the COVID-19 pandemic. Evidence-based strategies for overcoming barriers to vaccination in adults include things like system-based solutions, such as provider and patient reminders and recalls. But healthcare practitioner recommendation is among the most influential strategies. So don't minimize the power of your voice and your recommendation. It is really important for patients to hear that you, the clinician that they trust with their health, recommends strongly that they are vaccinated. Assessing the vaccination status at every clinical encounter turns it into a nice routine. And also, some visits the patients will not be open to it, but just because they're not at that visit doesn't mean that they won't be the next time. So really bringing it up at every clinical encounter, providing a strong recommendation, and offering it at every visit if possible. And in addition, having the resources already ready to go in your office, up-to-date, culturally competent, different language materials on hand for patient counseling on risks and benefits can definitely help eliminate some of those racial disparities in vaccination coverage. Thank you for listening, and I wish you and your patients lots of success getting vaccinated against shingles. Thank you.
Thank you very much to Dr. Restrepo and to you, our listeners, for joining in. As a reminder, to view the full educational program about shingles in the COVID-19 era, click on the link in the show notes. And please check back regularly for more episodes on important infectious disease topics. Thank you, and have a wonderful day.